uh, say a welcome message. Okay, good afternoon, ladies and gentlemen, colleagues and esteemed guests. It's an honor and privilege to welcome you all to the first session of the Hematology Grand Round hosted by Tehran University of Medical Sciences. Today, we gather to explore one of the most critical and evolving areas in the field of hematology, research and treatment of acute lymphoblastic leukemia in 2025. This session marks the beginning of the series designed to foster collaboration, share cutting-edge and knowledge, and advance our collective understanding of hematologic disorders. Before we proceed, I would like to extend our heartfelt gratitude to the international affairs of Tehran University of Medical Sciences for their unwavering support in organizing this event. Their efforts have made it possible for us to connect and learn from some of the brightest minds in the field. I also wish to thank all of you, our attendees, for taking the time to join us from various parts of the world, demonstrating your commitment to advancing hematologic research and care. Our focus today is on the future of ALL research and treatment with an emphasis on innovation, challenges, and opportunities in this dynamic field. As we all know, ALL is one of the most challenging forms of leukemia, but it's also one where breakthrough in research, clinical trials, and advanced therapies have shown immense promise. This session aims to shed light on these advancements and provide a platform for clinical discussion. Okay, this session will begin with a keynote presentation by our distinguished speaker, followed by a moderated discussion to delve deeper into key points raised during the talk. We will conclude with an interactive Q&A session where you, the audience, will have the opportunity to engage directly with our experts. I encourage you to share your question in the chat box as the session progresses, and we will address as many as time permits. Your participation is what makes this session truly valuable. Feel free to share your thoughts, question, or reflection as we go along. Together, we can create a meaningful dialogue that benefits not just our understanding, but also our clinical and research practices. It's now my great pleasure to introduce our keynote speaker, Dr. Hago Pantarjian. Dr. at the world-renowned MD Anderson Cancer Center in the United States. With a career spanning decades, he has been at the forefront of leukemia research and treatment. His groundbreaking work has not only improved survival rates, but has also set new standards for clinical practice and in hematology. Dr. Kantarjian's expertise extends to areas such as targeted therapy, innovative clinical trials, and improving access to care for patients globally. His contributions have been instrumental in shaping the future of leukemia treatment, and we are truly privileged to have him with us today. He will be sharing his insights on the advancement and challenges in the treatment of ALL as we look ahead to 2025. Following this insightful presentation, we are fortunate to have Dr. Saeed Rezai Juzdani as our moderator for discussion. Dr. Rezai is an associate professor of hematology and oncology at Kermanshah University of Medical Sciences. With extensive expertise in clinical research and hematology care, he brings a wealth of knowledge to this discussion. Without further ado, please join me in welcoming Dr. Hago Pantarjian to deliver his keynote presentation. Dr. Kantarjian, please start.
Thank you very much.
Dr.
Can you hear me well? Can you hear me well?
Yes, we can hear you.
And you can see my slides, right?
Yes.
Yes.
Okay. So I was having a lot of questions about the treatment of acute lymphocytic leukemia. So I thought giving an update on the management of this disease would be important, particularly that I believe that 3 to 5 years from now, the treatment of ALL is going to be very different from how we practice it today. So let me start by discussing what is the current therapy. The current therapy consists of over a dozen chemotherapy drugs given in intensive courses over about 2 to 3 years. And this treatment paradigm started in the 1960s, and it has been very successful in childhood ALL, where you see on the left side that the cure rate in cooperative trials and in cancer centers is close to 80 to 90%. When we apply the same treatment paradigm of the intensive chemotherapy for 2 to 3 years to adult ALL, and this is up to 2010 in blue, the 5-year survival is about 50%. It has increased recently with the introduction of the newer regimens, and I'll show you that by abandoning the old tradition and incorporating antibodies and targeted therapies, we are actually reaching 4-year survivals close to 80%. And that's why it's important to update the management of ALL consistently so that people know where we are with this treatment. Now, why is there still a difference in the cure rate of pediatric versus adult ALL? That's about 30%. I think it is, and this is with intensive chemotherapy. I think it is essentially related to maybe 4 main subsets, which have different incidences in children versus adults, and they have a very different prognosis with the intensive chemotherapy. So you have the hyperdiploid karyotype, which is a quarter of pediatric ALL, 5% of adult ALL, and these patients do well with intensive chemotherapy. Then you have the ETV6 ranks 1, which is also common in childhood ALL, less common in adult ALL. Again, it does very well with intensive chemotherapy. So about half of the pediatric ALLs and less than 10% of adult ALL do well with intensive chemotherapy. Then you have 2 subsets which are more common in adult ALL, and these are Philadelphia positive ALL and the recent Philadelphia-like ALL. And these constitute about half of the adult ALL and 15% of childhood ALL. And historically, they've done poorly with intensive chemotherapy, but I'll show you that this is not the case anymore, neither in Philadelphia positive ALL nor in Philadelphia-like ALL. So one of the questions is, if the treatment with intensive chemotherapy is so successful, why should we change it? And I think we need to change it because there's too much chemotherapy for too long. And while this is manageable in cancer centers in cooperative trials, it is not practical in the community practice, in non-urban areas, in younger nations. For example, in childhood ALL in India, the cure rate is less than 10% if a child is poor, but 80% if they are wealthy. So the question is, can we develop, as in lymphoma or other solid tumors, shorter regimens with less intensive chemotherapy, to which we add some of the targeted therapies and shorten the duration of therapy so it is doable in any setting rather than only in cancer centers? And I'll show you at the end what I call the dose-dense mini-CVD Enoblina regimen. Now, it is expensive because you have inotuzumab and blinatumomab, but it's given over 6 to 8 months, and perhaps in the future, when those drugs become generic, it will be affordable to all. And here I show the outcome in practice. So I mentioned that the cure rate in childhood ALL in cancer centers in published reports from cooperative trials is 80%. But when you look at the real-world practice, Peru and India, in children under the age of 10, the potential cure rate is only 50 to 70%. And when you get over the age of 10, the cure rate goes to less than a third of the patients. So what should we incorporate in the newer treatments? I'll show you that in Philadelphia positive ALL, we are using the more potent BCR-able TKIs like ponatinib, and we're combining it with a CD19 antibody drug conjugate with a CD19 bispecific T-cell engager. It's called blinatumomab. And we're using now minimal chemotherapy, and we're getting very good results. In pre-BALL, we are incorporating both blinatumomab and also a CD22 antibody drug conjugate called inotuzumab into the chemotherapy. We're also starting to use the CAR T cells as consolidation instead of transplant in remission. And very importantly, we are starting to track people not by flow cytometry MRD, but what we call a next generation sequencing clonoSEQ for the immunoglobulin heavy chain disease. So it is particular to every patient. It analyzes about 3 million cells. And even if you have 2 to 5 leukemia cells in a million, those patients are destined to relapse. So this allows us to change therapy very quickly in terms of adding CAR T cells or modifying the chemotherapy. So I'm going to start with Philadelphia positive ALL. This is about maybe 25% of adult ALL. And before 2000, we did not have BCR-able TKIs. We treated the patients with intensive chemotherapy, and the CR rate was about 80 to 90%. When we could get them to a transplant, the cure rate was 35%. But without transplant, the cure rate was 10% or less. So this was one of the worst acute lymphocytic leukemias to encounter. Fast forward to today. In 2000, we added imatinib to hyper-CVAD. In 2006, we replaced it with dasatinib, a more potent BCR-able kinase inhibitor. And in 2010, because we saw patients relapsing with the T315I mutation, we started using ponatinib. The patients were living longer, so we started seeing CNS relapses. We increased the intrathecals to 12. And then in 2017 came the next inflection point in therapy. So the first inflection point was in 2000, where we added the BCR-able TKIs. The second inflection point was in 2017, where after we found that blinatumomab was better than intensive chemotherapy, even in Philadelphia positive ALL, we went into non-chemotherapy regimens with ponatinib blinatumomab. Now, because we removed the high-dose Ara-C and methotrexate, we started seeing more CNS relapses. So we increased the intrathecals to 15. And now we do not use allogeneic transplant that often. So this is the hyper-CVAD ponatinib regimen up till 2017, 8 courses of intensive therapy, pump maintenance, and then the ponatinib maintenance indefinitely at a lower dose. So once the patients achieve a complete molecular response, we go down to 15 milligrams daily. And these are the published data recently in 86 patients. Most of them achieve a CR. PCR negativity is 84%, and the 5-year survival rate shown on the left side is about 75%. So this was very good. And for the first time on the left side, we started noticing that the patients who go to transplant actually do worse than the patients who don't go to transplant because of the transplant-related mortality. So we started not doing the transplant unless there is persistent molecular disease by NGS after 3 months of therapy. Now, somebody might say, well, imatinib is generic, commercially available, cheap. Why should we use ponatinib? And here I show a study in childhood ALL where they compared dasatinib to imatinib with intensive chemotherapy. And they showed that the use of dasatinib improved the survival. Now, notice in children, even with the milder regimens, the 4-year survival rate is very high, 70%, as opposed to much less in the adult ALL. But it increases to 90% with the use of dasatinib. So one could say, well, I'm going to use dasatinib instead of ponatinib because, again, dasatinib is generic. But then you could encounter the problem of relapse with T315I mutation. So the rationale for changing the treatment were threefold. The first one is we started noticing that 3/4 of the relapses were with the T315I mutation shown on the left side, so we changed to ponatinib. The second is shown in the middle. Dr. Rambaldi showed that blinatumomab is better than intensive chemotherapy in the patients who are receive antibodies. So this we decided to use blinatumomab instead of inotuzumab in this setting because there was also data for that. And the last thing was the increase in the incidence of CNS relapses as the patients were living longer. So this was with intensive chemotherapy. When we increased the intrathecals to 12, we did not show any more CNS relapses. But I'll show you that since we removed all the intensive chemotherapy, we are seeing CNS relapses. So now we increase the intrathecals to 15. So this is the regimen that we use today. We induce the patients with ponatinib, 30 milligrams daily, and blinatumomab starts with the induction 4 weeks, every 6 weeks for 5 treatments. And as soon as the patients are in a complete molecular response, which is usually within 6 weeks, we go down on the ponatinib to 15 milligrams. And my practice is to give all patients baby aspirin. I think it's a better way of preventing veno-occlusive disease. And now the ponatinib is indefinitely, but I'll show you that we have data that we can stop it after 5 years of a complete molecular response. So on the left side is the PCR data, which is what we all use to monitor Philadelphia positive ALL. And what you see is by the beginning of the second course of blinatumomab, 6 weeks into the treatment, 2/3 of the patients are PCR negative. So it happens very quickly. Now, the NGS, I think, is better than the PCR because it looks at 1 million cells rather than 100,000 cells. And by course 3, most of the patients have become NGS MRD negative. Now, another twist to this is there are some patients who are PCR positive, but NGS MRD negative. So these patients do not relapse. And the question is, well, where is the signal coming from? And I think it's coming not from the lymphoblast, but from myeloid cells. So if you see a patient who is PCR positive continuously, try to do the NGS MRD. And if it's negative, it reassures you that this patient does not have to go to transplant. So this is the most updated results of the ponatinib blinatumomab. We just published it in JCO with an update at the ASH meeting. 76 patients treated with the simultaneous combination. Only 2 patients had to go to transplant. We give 5 courses of blinatumomab, 15 intrathecals, and the 3-year survival rate is close to 90%. So we're doing very well with the 3 and 4-year survival rate. And what you see is that the NGS MRD negativity is now 96%. So these are all very good results. Now we started noticing that those relapses which are happening are in patients who start with a high white cell count. And what you see is in those patients, you need something other than just the ponatinib blinatumomab. So in these patients, we are adding again 2 courses of high-dose methotrexate Aracib. Now, there are other people who are doing the same thing. So this is from the ASH meeting by Dr. Shariati from Italy, where they used also ponatinib blinatumomab, but they have 2 differences. The first one is they use ponatinib at the higher dose in the younger patients, which I think is a problem. And the second thing is they use the blinatumomab 3 months into the induction rather during the induction. They still have good results. So after the blinatumomab, the CR rate is 98%, and the MRD negativity is only 73%. So I think our strategy may be better. And they reported 90% survival in 1.5 years, but they do require those reductions of the blinatumomab in 40% of the patients, because they see liver toxicity, pancreatitis, and cardiac problems. So I think 30 milligrams a day during the induction is better than 45 milligrams a day. Now, on this slide, I showed the summary of the 5 studies that used non-chemotherapy regimens. 2 of them are the ponatinib blinatumomab with 5 blinatumomab. This is our study, 4-year survival, 88%. The ponatinib blina from Dr. Shariati in Italy, they do not have a long-term follow-up yet. So still 90%, 92% survival at 1.5 years. And then 2 studies with dasatinib blinatumomab, where they showed that you have to go to transplant in these patients, because if you don't go to transplant, you get a lot of relapses, including T315I relapses. So this study was in older patients, median age 73. They could not take them to transplant. Only 5% went to transplant. And they do see relapses with the T315I mutation, and the 4-year survival is worse than what we have. So I really think by luck or by experience, our ponatinib blinatumomab is still the best approach, but we have to reintroduce some high-dose RC therapy in the patients who present with a high blast count at diagnosis. Now you could say, well, I don't have the affordability or the means to do continuous therapy with ponatinib blinatumomab. I want to rely on the allogeneic transplant, because in some countries the transplant is only $20,000 to $40,000, and it's a one-time procedure. So actually, the Germans did that. So they reported at this ASH meeting 174 patients. Notice they are all under the age of 55, median age 42. And they used imatinib instead of dasatinib or ponatinib with low-intensity chemotherapy, and then they moved all patients to transplant. So of the 174 patients, 91% went to transplant, including almost all patients who achieved the CR, and the median time to transplant was 4 months. So look at the 3-year survival. It's 76%. And that's because there is a transplant mortality of 16%. So even in a younger population in Germany, all under the age of 55, the transplant mortality is 16%. So that's the price to pay if you want to rely on transplant as economically feasible procedure in patients with Philadelphia positive ALL. Now, one could also say, well, I cannot afford giving dasatinib or ponatinib indefinitely. Is there a time that we can stop safely? So as you know, unlike chronic myeloid leukemia, where we attempted TKI discontinuation and treatment-free remission, because if the patients relapse, they relapse at a molecular relapse, so you could reintroduce the TKI. In Philadelphia positive ALL, there is the fear that if you stop, the patients will not relapse molecularly, but they will relapse with active ALL and they lose the chance of a cure. So we went back to our data and we found 14 of 238 patients who stopped therapy on TKIs, and they stopped it because of toxicity, pleural effusions, arterio-occlusive event, pulmonary hypertension, pancreatitis, and so on. And what we noticed is, in fact, when we stopped therapy after 4 years of a complete molecular response, the patients did not relapse. So now, like in chronic myeloid leukemia, we can test prospectively patients who achieve a complete molecular response, not only by PCR, but by NGS, MRD. And if they are in a complete molecular response for 4 to 5 years, we could try to taper the TKI or stop it and see if they are curable. So this is our current regimen, the same as I showed you before, except now in yellow, we are adding 2 courses of high-dose methotrexate RC at the time of achievement of a complete remission. And this is only in patients with a high white cell count at diagnosis. And this shows the survival curves in red of the ponatinib blinatumomab compared to the hyper-CVAD ponatinib and compared to the hyper-CVAD dasatinib in green and hyper-CVAD imatinib in orange. So a big difference in the outcome, perhaps justifying the added burden and expenses. Next, I'm going to talk about B-cell ALL, and this is where the immune oncology has revolutionized the treatment, and it is divided into two components: immune therapy with antibodies that target CD19, like the bispecific T-cell engager blinatumomab, and antibody drug conjugates that target CD22, like inotuzumab. But also, we will look forward to the newer bispecific T-cell engagers targeting CD20 because they are more potent than rituximab. So it's possible that in the future, we will use 3 antibodies without chemotherapy at all and with CAR T cells to cure acute lymphocytic leukemia. The second breakthrough came with the CAR T cells, but as you know, the CAR T cells today are used in active disease, and when we do so in adult ALL, it can cure only maybe 30% of the patients. So perhaps it is better to use the CAR T cells in the setting of minimal residual disease like we do with allogeneic transplant. So at the beginning, we did randomized studies that showed that blinatumomab and inotuzumab were superior to standard of care intensive chemotherapy in the setting of refractory relapse ALL. On the left side is the blinatumomab versus chemotherapy, higher CR rate and better survival. On the left side is inotuzumab versus chemotherapy, again, higher CR rate and perhaps better, longer survival. But notice we're paying a lot of money for not much of a cure rate. And so if we continue to use blinatumomab and inotuzumab as single agents in refractory relapse ALL, we're not getting a lot of return on our investment. So as soon as those 2 antibodies were FDA approved, we started using them in combination with chemotherapy in both the frontline and the salvage. So I'm going to start with the frontline younger patients under the age of 60, where we started using hyper-CVAD for 4 courses instead of 8 courses. And then we replaced the other 4 courses with sequential blinatumomab. And the third modification was to reduce the pump maintenance from 2.5 years to 1 year with some blinatumomab in between. Later on, we added fractionated inotuzumab in the 2 even courses of the methotrexate Ara-C, but we reduced the dose of methotrexate and Ara-C to avoid the cumulative myelosuppression, and we added it to 2 courses of blinatumomab. So now I'm going to show you the update with the hyper-CVAD blinatumomab sequentially and with the addition of later inotuzumab. So all of the patients achieved the CR. NGS MRD negativity actually is 90% now. And look at the 4 to 5 year survival. For the first time, we're looking at 3 to 4 year survivals, which are over 80%, which is as good as you get in childhood ALL. In the middle is the curve when we added the inotuzumab later on. So there are relapses, but the patients are not dying yet because we have effective salvage therapies. And this curve shows the current regimen compared to the previous hyper-CVAD of ofatumumab. So at 4 years, we're able to perhaps claim an improvement in the survival from 60 to 80%. Now let's look at the high-risk disease. So Philadelphia-like ALL, where the outcome used to be a 4-year survival of 25%. Even in the high-risk ALL, the 4-year survival has gone to over 70%. And on the right side, I show that we do not need to do the transplant except in the high-risk ALL. So patients with KMT2A rearrangement, 5 chromosome abnormalities or worse, or a near haploid karyotype, and I'll show that later. And we're not the only people who are doing this. So the top two lines are the hyper-CVAD blina and hyper-CVAD blina inotuzumab. I showed you the results. But what you see is that other people are including mostly blinatumomab in this setting with reasonably good results. So the CR rates are very high, MRD negativity are very high, and the early data is showing good results. Now, I want to show this publication by Dr. Lisso in the New England Journal of Medicine. So this is a similar study, but instead of using the antibodies very early, what they did is they took 488 patients. They gave them 2 to 3 cycles of intensive chemotherapy. And then the patients who became MRD negative, which are only half of the patients, were randomized to 4 courses of blinatumomab or continuation of chemotherapy. And what they noticed is a big improvement in the 5-year survival rate, where the 5-year survival rate increased from 55 to 85%. But this is not the total denominator. This is half of the patients. So you expect the 5-year survival to be less than this, which suggests that our strategy of starting the antibodies earlier is better than starting them after 2 to 3 courses of chemotherapy, where you already lose about half of the patients. Now, what about blinatumomab in other settings? So here I show infant ALL, which is not my area of expertise, but it shows that in infants with ALL under the age of 1, most of them are KMT2A. When the investigators from Europe added only 1 course of blinatumomab to chemotherapy, they showed an improvement in the 2-year survival compared to historical controls from 66 to 93%. And at this ASH meeting, there was another similar study from England where they took 27 infants, they reduced the chemotherapy by 50 to 90%, they added 1 course of blinatumomab, and they reported similar survival rates of 93%. So this is only with 1 course of blinatumomab. So perhaps by using 2 to 4 courses, you will prevent the relapses and get better results. Now, there was also at this ASH meeting an update of this pediatric study where they looked at over 2,000 patients, and 1,440 had intermediate risk disease, and they randomized these patients to chemotherapy alone or chemotherapy plus blinatumomab up to 2 courses, and they reported that the outcome is significantly better. The 3-year disease-free survival increased from 88 to 96%, and I show here on the right side the disease-free survival and the reduction in the relapse. So now we know that blinatumomab is approved for minimal residual disease. It is approved based on the Lisso study in patients who are even MRD negative, so that covers all the adults. And now we have the pediatric and infant studies that show that blinatumomab is useful. So as of today, we should probably try to incorporate blinatumomab in all our regimens across all age groups in acute lymphocytic leukemia, as I showed you. Now, the question is how many courses of blinatumomab? I showed you that in infant ALL, 1 course may be enough. I showed you that in pediatric ALL, they use 2 courses. And then I showed you that in the Lisso study, they used 4 courses. And at MD Anderson, we use 7 courses. So which is the better outcome? So here I show again the Lisso study where they took those same 224 patients. And this is the survival, which I already showed you. And then they divided them into the patients who took only 1 to 2 courses versus patients who took 4 courses. And they showed that 4 courses is better than 2 courses which is better than nothing. So I think at least 4 courses of blinatumomab is good. And at MD Anderson, we're going to stay with 5 to 7 courses. How about minimal residual disease? So again, here I show in pediatric ALL, persistent residual disease is associated with the worst survival, but the 10-year survival is still 50% compared to adult ALL with intensive chemotherapy where the 4-year survival is as low as 20%. So there were studies with giving 2 courses of blinatumomab, but at MD Anderson, we used 5 courses of blinatumomab. And what we showed is the 4-year survival increased from 20% to 60%. It was better in patients with less disease burden. That's why we have to do the NGS MRD. And we do not show that following that with transplant improves the outcome. So because of the mortality of the transplant, so we're going to follow that with CAR T-cell therapy. Now let's look at the older ALL. So as you know, older patients over the age of 60 do not tolerate intensive chemotherapy. And the SEER data from the United States shows that with traditional intensive chemotherapy, the 5-year survival is 10 to 15%. That's the best you can get in older ALL with intensive chemotherapy. So at MD Anderson, we piloted less chemotherapy, what we call the mini CVD, to which we added the inotuzumab fractionation, and we followed this with 4 courses of blinatumomab and pump maintenance. And what you notice is to avoid the veno-occlusive disease, we capped the inotuzumab at 2.7 per meter squared, and we use ursodiol as VOD prophylaxis. And what we showed is we showed that we can double the 5-year survival rate. Now, this is still not ideal, so we're going to try to do less chemotherapy and use the CAR T cells as a consolidation in these patients. Now, why do those patients not do as well as the children? I think there's one caveat to older patients with ALL, where we notice that they have a high incidence of TP53 mutation. And in fact, in those older patients, if they have a P53 mutation also, they have a strong likelihood of developing MDS or acute myeloid leukemia. So look at the patients who are over the age of 60 with TP53 mutation. At 5 years, 1 in 4 patients develops either MDS or AML, and then they become incurable. So we think that it is the selection of the chemotherapy pressure that allows those TP53 clones to expand as myeloid clones. So we're going to lessen the chemotherapy and give the CAR T cells as a consolidation to avoid this quarter of the patients who might develop MDS or acute myeloid leukemia if they survive the acute lymphocytic leukemia. So I showed you the data with mini CVD in Oblina in 83 patients, high CR rate 99%, 5-year survival 50%. Again, other groups are doing the same, and now they are either using inotuzumab or blinatumomab as a consolidation, and some of them are omitting the chemotherapy, but they are not showing very good results without any chemotherapy. And that's where the CAR T cells might be helpful. So here I show a publication in JCO from Dr. Chevalier. So this is from France to show you that another group that has reasonably similar results. So they treated 135 patients. Notice that they include patients 55 to 60, which I think why the results look good. If you include only 60 and older, the results will be worse. They start with inotuzumab as a pre-phase, up to a total dose of 2.8 milligram per meter square. Then they give 6 chemotherapy consolidations. They show a CR rate which is very high, the same as ours, MRD negativity rate 80%, 4-year survival 41%, and they do not show much veno-occlusive disease, but that's because they do not send the patients to transplant, and they limit the inotuzumab to 2.8 per meter square. If you use more inotuzumab, you're going to have more veno-occlusive disease. So again, another study of low-intensity therapy with inotuzumab where the results were reasonable. Now, what about veno-occlusive disease? So at this ASH meeting, there was an abstract in 108 patients with refractory relapse ALL, where the patients received inotuzumab, and they showed that the incidence of veno-occlusive disease went up to 30%, and it is 20% in the patients who went to transplant. They did a multivariate analysis, and they showed that spacing the time from the last dose of inotuzumab to the transplant by at least 2 months reduces the incidence of veno-occlusive disease. So this is what actually we're doing now with the mini-CVD inoblina, where we incorporate the blina after the mini-CVD ino, so the transplant is distanced, and this is why we have a much lower incidence of veno-occlusive disease than the childhood ALL, and I'll show you that in a second. Now, what about T-cell ALL? So T-cell ALL, we do not have targeted antibodies, so we use a lot of intensive chemotherapy with high-dose methotrexate Ara-C asparaginase, and we started incorporating nelarabine and venetoclax. And what so we know that there's a subset of T-cell ALL, which is the precursor T-cell ALL, which has a genotype similar to AML. So this is the general T-cell ALL, and this is their genomic profile compared to AML. So what you notice is there's this subset, which is the precursor T-cell ALL, that has a genotype similar to AML, and we think that the precursor T-cell ALL may benefit from adding AML-type therapy, like venetoclax, like decitabine, and so on. So this is the regimen that we use at MD Anderson. We had to change it quite a bit over time because we were not getting very good results. So the current regimen is with hyper-CVAD, to which we add nelarabine asparaginase, and also we add venetoclax in the regimen. And we have reported on this recently, and we showed that with this regimen, the CR rate is very high, about 90%, and the 5-year survival is 64%. And I show on the right side the results with the 2 more recent studies where we added both nelarabine and venetoclax, and the 3-year survival is close to 70 or 80%. So we're happy with the current regimen. Now, there are CAR T cells being developed against CD7 T-cell ALL. This is a study from China published in 60 patients with refractory relapsed childhood ALL, median age 19, so not that much of a childhood ALL. And what you notice is that by giving them the CAR T cells, almost all of them achieve a remission, and the 2-year survival is 60%. So this is a very good CAR T cell that we are trying to get into the United States to incorporate into T-cell ALL therapy. So then we come to the role of allogeneic transplant. When do we do allogeneic transplant in ALL in first remission? Certainly in every patient with KMT2A, because the genotype sometimes overrides the NGS MRD negativity. So you could have a patient with KMT2A ALL that becomes NGS MRD negative. They are still going to relapse. Patients with 5 abnormalities or more, or low hypoploidy, also relapse. And patients who are Philadelphia-like with a JAK2 mutation, they also relapse. So these are the 4 categories of ALL where we still do allogeneic transplantation. or CAR T cell in first remission, even if the patients become NGS MRD negative, because it is not only the MRD status, but the original genotype of the patient that may matter. So high-risk genotype patients will still relapse. So let's look very quickly at ALL in first relapse. So in adult ALL in first relapse, and this is a total of 1,000 patients in 2 studies, in the adult patients who relapse, it is still a death sentence where the 5-year survival is less than 10%. So again, we use the mini CVD Inoblina regimen, which we used in the older ALL. And this is the update in the Journal of Hematology Oncology. In 125 patients, they are all refractory relapsed ALL, where the 5-year survival is expected to be 10% with intensive chemotherapy. We get a marrow CR rate of 83%, and the 5-year survival is 40%. This shows when we added the blinatumomab. So in this setting, we added the blinatumomab later on because the company gave us that later on. So when we add the blinatumomab, so the combination of Ino and Blina is better than the mini CVD Ino. And this is where the 3-year survival gets to be close to 50%. And the transplant is not improving the outcomes, so we're going to use CAR T cells. Now, here, in the relapse refractory setting, the incidence of veno-occlusive disease was overall 8%. It was 13% before adding the blinatumomab to distance the inotuzumab from the transplant. So after we added the blinatumomab and we're using ursodiol, and we're capping the inotuzumab, the veno-occlusive disease is only 2%. So I think we have a good strategy. And this is in salvage 1, again, 5-year survival 40%, and this is transplant, no transplant. Now, I was interested in this publication at the ASH meeting because it showed that fungal prophylaxis in ALL is important. So at MD Anderson, we always practice fungal prophylaxis, but also Levoquin Valtrex. If you use fungal prophylaxis with an azole, you have to always make sure that you stop it the day before, the day of, and the day after the vincristine, because if you use azoles with vincristine, you increase the incidence of neuropathy. But they did show that fungal prophylaxis reduced the incidence of invasive fungal disease from 22 to 11%. And by multivariate analysis, the fungal prophylaxis was the most important factor, and fungal infections occurred in patients who have neutropenia and who are on steroids. So this is typical ALL, and we need fungal prophylaxis. In the last 2 minutes, I'm going to show you 2 studies which are also going to uproot everything I told you about in the last 50 minutes. So the first one is subcutaneous blinatumomab. So subcutaneous blinatumomab is not only more convenient because you give it daily for 7 days than 3 times a week, but we can also deliver 5 times more the dose. And by doing that in a small number of patients, 27 refractory relapse patients, the marrow CR rate was 90%, and the median survival was over a year. So much better than the results of single-agent blinatumomab. So we're going to try to replace IV blinatumomab with subcutaneous blinatumomab in all our studies as soon as possible, not only for convenience, but also for the efficacy of the subcutaneous. And the last thing I'm going to show you is what I call the dose-dense mini-CVD inotuzumab blinatumomab, and we're going to call it also the BRIC regimen. The BRIC stands for blinatumomab, rituximab, or a CD20 antibody, inotuzumab condensed with chemotherapy. So rather than giving the blinatumomab sequentially, we started on day 5 of every course of chemotherapy in the first 4 courses. We add inotuzumab in the first 4 courses. Then there are 2 more courses of chemoblina. And then as of today, we're still doing maintenance. And I wanted to show you the data in the refractory relapse patients. So these are patients in first relapse. We have only 22 patients. All of them achieved the marrow CR rate. NGS MRD negativity, amazing, 94%, and a 2-year survival of 80%. This is as good as frontline therapy. And on the right side, I show the green curve, which is the dose-dense mini-CVD in Oblina versus the previous study that I showed you with the mini-CVD followed sequentially by blinatumomab or with the mini-CVD alone. So I really think in the future, we could potentially practice an approach where we can give a dose-dense mini-CVD in Oblina for 6 courses, followed by CAR T cells. Now, you could say, well, you keep talking about the CAR T cells, but the CAR T cells are toxic. They have a lot of cytokine release and neurotoxicity. Well, that's true for the first 2 FDA approved. It is not true for the newly approved obe-cel, which is a fast-off binder. And it was just FDA approved in the United States. Now, it has as good results as the previous 2 CAR T cells, but the incidence of cytokine release syndrome and neurotoxicity is less than 10%. So there are CAR T cells which are safe that we could use as a consolidation instead of allogeneic transplantation. So in summary, I think 5 years from now, we will probably be treating ALL, Philadelphia positive ALL with ponatinib or dasatinib and blinatumomab, but we have to add intensive chemotherapy to the ones which start with a high blast count. And we're going to use much less chemotherapy in combination with antibodies. And we're going to monitor every patient with the clonoSEQ in order to intervene very early, even at the time when there are 5 leukemia cells in a million cells. And now we're looking at better antibodies like the subcutaneous blinatumomab and also the longer-acting CD19 antibodies, which are given by vein every 2 weeks. And AstraZeneca has one of them, and there are others. So the future, I think, is going to be hopefully with 6 courses of dose-dense, low-intensity chemotherapy with the better antibodies, and then CAR T cells, and then stop if the NGS clonoSEQ is consistently negative. So thank you for your attention, and I'm happy to answer any questions. So if you like, I can go to the Q&A. You're muted, Dr. Rezain.
Yes, it's our pleasure to have your presentation and see your slides. Very good target therapies. But one of the things that I want to say is that in our country, we do not have access to many of the new therapies research and the new target therapies such as blinatumomab, inotuzumab, monoclonal antibodies, and but we have stem cell therapy. Do not have we do not have CAR T cell therapy, and we do not have access to that. What is your opinion about low-income countries and the modification for our regime?
So I think if you have if you do not have blinatumomab, inotuzumab, or the CAR T cells, you have to use the chemotherapy regimen that you are most comfortable with, but possibly monitor the patients by NGS MRD. If they are negative, I would not take them to transplant. If they remain positive or if they have high-risk genotype, I would take them to transplant.
Nice. May I ask a question from one of my colleagues? Dr. Amir Abbas Rashidi. He asked that regarding the therapy-related BALL, do you recommend an allogeneic hematopoietic stem cell transplant, or should we follow the same criteria as de novo ALL when deciding on stem cell therapy? Do we have a term which has therapy-related BALL, and what is the response of the answer?
So this is a very important question because we're starting to see many more patients with ALL who develop it after a treatment for myeloma, autologous transplant, and maintenance with and maintenance therapy. And those patients particularly are the ones over the age of 60, and they have a TP53 mutation at the start. And that P53 mutation is in the lymphoid clones. But now, as we treat them, as I showed, a quarter of them are developing MDS or acute myeloid leukemia. So if you have a patient with therapy-related B-cell ALL, particularly after myeloma therapy, or if they have a TP53 mutation, I would recommend that those patients go for allogeneic stem cell transplantation.
After induction therapy and getting MRD negative data. Okay.
Right. So I would not rely on the NGS MRD in these patients because a quarter of them may develop MDS or AML, and then they'll die from it. You cannot help them anymore.
The next question, Dr. Rizvani, my professor, said that our patient is 60-year-old. The patient is diagnosed with ALL-P positive, and he has experienced CNS lab while on treatment with imatinib on maintenance phase. MRD was negative in bone marrow. The patient had
Kidney dysfunction.
1.7, which prevented us from administering high-dose NPX after CNS relapse. We initiated treatment with triple intrathecal therapy combined with dasatinib. However, the patient has developed recurrent pleural effusion, which persists despite the therapeutic cross-sympathy. CSF cytology is negative now, and Conative is not available in Iran. What is your recommendation to this?
So this is a 60-year-old. The creatinine is not that bad, 1.7. He had only CNS relapse, so he received the triple intrathecal therapy, I presume, and until it became negative. There are two choices. The first one is to still consider a high-dose RC regimen, but at 1 gram per meter square daily for 3 days with fludarabine, and you can adjust the fludarabine dose. Or you have to do craniospinal radiation with the intent of a cure. But I think once the patients relapse in the CNS, they have the potential of relapsing systemically. So I would try to do at least 1 or 2 courses of fludarabine high-dose RC without the methotrexate.
Do you recommend stem cell transplant for this patient?
Not for isolated CNS disease. So what I would do in this patient is you have done the triple intrathecal therapy twice weekly until negative, then weekly for 4 times or 8 times. So maybe a total of 12 to 16 triple intrathecal therapy. You could do 2 courses of 3 days of fludarabine high-dose RC. So the RC is only 1 or 1.5 gram per meter square. And then you can ask the radiation therapist to do a consolidation craniospinal radiation therapy. And I think that should be enough.
Yes. May I ask the next question?
Dr. Rezai, Dr. Diglari has a question. He can raise his hand and ask the question directly. Dr. Diglari, if you can hear me, please raise your hand and we can give you the microphone. You can also
While I
ask.
While I get Dr. Bligari, there's the question from Dr. Kamran. What is the threshold for CD19 or CD22? We do not have a threshold for those. With single agent therapy, for effective results, the threshold has to be 50%. But in general, almost all patients with ALL are CD19 or 22 positive. So we give it to all the patients regardless of the threshold. Dr. Biglari, do you want to type your question while we're looking at other questions?
یادمون رفته تو بگو زنگ میزنه سر کلاس بگو زنگ.
Dr. Kantarjian, Dr. Ali Mohaddam also asked a question. Did you respond that how much is the threshold of CD19 and CD22 for this kind of treatment?
Yes, I said there's no threshold. With the single agent therapy, the threshold is over 20%, and for a good response, it has to be 50%. When we do it in combination with chemotherapy, we don't have a threshold because almost all the patients are positive. So the question is, what is my opinion about targeted therapy like venetoclax or cardizomib? So for venetoclax, I think it is effective therapy. The problem is it was outcrowded by the antibodies, which were much more effective. That's why we started using it in T-cell ALL, because we don't have antibodies there. But I do think that venetoclax works in pre-BALL. So if venetoclax is available in Iran, what you may want to do is design your own studies with chemotherapy venetoclax. So you could do venetoclax 7 days with every course. You have to be careful. In ALL, we noticed that even when we give 7 days of venetoclax with the chemotherapy, for some reason, in the T-cell ALL, the patients become very myelosuppressed. So you have to work your way around using venetoclax. But in the precursor T-cell ALL, we've noticed that venetoclax combinations with a hypomethylating agent works very well in the setting of salvage therapy. So you could try to induce some of your patients into remission with that approach. And then in the light of the promising results of blinatumomab, do you follow trials with these drugs? So all our studies today are incorporating blinatumomab with chemotherapy. We do not have any regimen that does not have blinatumomab or inotuzumab at MD Anderson. And the other question of Dr. Biglari is carfilzomib. And I know that in children, they use it a lot and they believe in it. In adult ALL, we have not seen any positive results with that. Dr. Kamran is asking, in our country, new drugs are not available and the chemotherapy or the transplant is cheap, and the MRD tests are not validated. So it would be a difficult situation. I think you have to, as a group of expert heme oncologists, try to certainly get the MRD testing in Iran, or you can send it to the drug company. And perhaps within the next 3 years, we're going to start seeing maybe generic formulations of inotuzumab and maybe blinatumomab.
Next question. In therapy-related BALL patient like this case, where stem cells were preserved during previous treatment for multiple myeloma, if the patient becomes unable to continue chemotherapy due to hypocellular marrow during hypercellular treatment, and considering the patient does not have a full match donor, is autologous stem cell transplant is a viable option in such circumstances. Furthermore, could autologous stem cell transplant be combined with blastoma maintenance therapy as an alternative approach?
So I think autologous transplant in this particular case is a viable option if the autologous cells were preserved at a time when the myeloma was not there anymore. And so I think the autologous stem cell would be a viable option instead of the allogeneic transplant. Because the reality is in ALL, the graft versus leukemia effect is much less than in AML. So if you're giving the intensive chemotherapy and giving back a clean autologous marrow, then it could work for this patient. And then Dr. Marjan Tagrian, is a child with MLL rearrangement in first CR a candidate for allogeneic transplant, or is it only a child under the age of 1? So I don't know the answer to this question because I do not have much experience with childhood ALL, so I do not know the outcome of KMT2A ALL in a child over the age of 1 in first remission. This is where the NGS MRD could help you decide on whether to do an allogeneic transplantation or not. But I'm not an expert in children with ALL, so you have to ask a pediatric ALL doctor about this particular child who's over the age of 1.
Thank you. Any question anymore from our colleagues?
Just to follow up for Dr. Marjan, looking at the infant ALL where their 2-year survival with chemotherapy is only 50%, I would think that a child with MLL KMT2A may benefit from a transplant. But again, I don't know. So do you agree with the multicolor flow cytometry for MRD evaluation? So it depends on the multicolor. If you're using 4 colors, then your sensitivity is only 1 in 1,000 to 1 in 10,000. If you use 8 color, you could go up to a sensitivity of maybe 10,000 to 100,000. So it is still less precise than NGS MRD. And as I mentioned, we have now patients where we see 2 or 3 leukemia cells in 3 million cells, and those patients are relapsing. So we are intervening at the setting of very little minimal residual disease, even less than 5 leukemia cells in a million. We're offering CAR T cells, we're offering antibodies. So I think it is important to try to get the NGS in Iran for patients with ALL.
Okay, any audience have more questions? Dr.
Do
Bigler?
you think hematopoietic stem cell transplant is the best option for extramedullary relapse like CNS or testis, or you recommend adjuvant drug conjugate?
So I don't know the answer to that. I know that blinatumomab does not work well with extramedullary disease. I know that inotuzumab works in extramedullary disease, but not CNS disease. And the CAR T cells work very well in CNS disease. So in general, yes, I would think that a stem cell transplant would be a good option for extramedullary disease. If it was at MD Anderson, I would probably do inotuzumab before that, and then CAR T cells, or inotuzumab and then transplant. And the final question from Dr. Rashidi, is there a specific chemotherapy regimen that works better to prepare for stem cell transplant compared to others? No, I don't think so. We often use fludarabine, idarubicin, Ara-C, so the FLAG-IDA regimen that we use in AML, and that works very well. We add pegylated asparaginase to that, and we try to incorporate. So to answer briefly, Dr. Rashidi, in Iran, I think the FLAG-IDA regimen would be a very good preparative regimen for transplant, before transplant. Given the presence of cell antigens on T cells, how do you address the issue of using CAR T cells? So that was actually the reason why the CAR T cells could not be developed for 4 to 5 years, because of the fratricide. So the CAR T cells killing not only leukemia cells, but killing the patient's T cells. Now, somehow, there are technologies that avoid the fratricide, and it seems to be successful with the CD7 CAR T cells. I know that there are CD4 and CD5 CAR T cells under development, but they are not as successful. So the new CD7 CAR T cells from China are avoiding the fratricide, and at the same time, they are effective, as I showed you in that one slide.
Any other question? Okay, if there is no other question, I would like to express my sincere gratitude to our speaker, organizer, and all of you, our participants, for making this session a success. Your engagement and thoughtful contribution have made this a meaningful experience for everyone involved. This marks the beginning of our Hematology Grand Round series. We hope to continue this journey of learning and collaboration with you. Please stay tuned for upcoming session where we will delve into other critical topics in hematology. Thank you once again for your time and dedication, and wishing you all continued success in your endeavor. And have a wonderful day. Thank you, Dr. Kantarjian.
Thank you for inviting
Thank you.
me. Thank you.
Thank you, Dr. Kantarjian. Thank you for your time. And it's my pleasure to introduce you to my colleagues and answering my questions. It was very pleasure, and I appreciate that.
Thank you for inviting me, Dr. Rezai and Yarmai.
Thank you.
Take care. Bye-bye.
Bye.
Take care.